So today's my talk is all down to the basic science of blood flow restriction training. And as he already talked to us, that there are my team, Rob Duffy, who is our physiotherapist, who unfortunately got COVID and he's still not back from work. He's got a slightly long COVID. Hopefully he hasn't got a long COVID, got a slightly long one in the moment. So he had recorded this message with us. He recorded this video with us, and I would like to present that to you in terms of a randomized controlled trial with the blood flow restriction training. And after that, we got Paul Lewis, who is a consultant nurse working into our clinic, have a wealth of knowledge of how to use blood flow restriction training as well as rehabilitation. So first of all, let's kick off with my talk, which is the basic science of blood flow restriction training. All right, so I would like to first introduce, where is it gone? Here it is. There you go. So I would like to introduce myself. So I am a orthopedic surgeon. I specialize in lower limb surgery, and my chair is on visiting chair is on sport medicine and also rehabilitation to help athletes to return back to the top forms. I work in MSK Doctors, and we believe in the biology and regeneration pathway. We are a recognized teaching center of excellence for International Cartilage Regeneration Society for cartilage regeneration. So I have a great interest in how I can try to get our patient back and how we can improve rehabilitation with different techniques. We have been looking at BFR or occlusion training for quite some time. So let's go through about some of the science that we're going to talk about. Now, today's lecture, you can learn a few things from this lecture, or maybe some of them you might not learn, maybe you knew already. It is just a bit of a refresher to some people. So first of all, we want to talk about the basic science of muscle energy metabolism. Why do we need oxygen in our body? What is the Krebs cycle? How do we build muscles in our body? You may or may not have heard of, or you may be very familiarized with the AKT-mTOR pathway, which is how our body builds muscles, and how we can think differently to attack this pathway and trick our body into a recovery mode. And then we're going to talk about what is BFR and are there any clinical evidence out there. And just a bit of spoiler alert, yes, there is. There is a meta-analysis on BFR, which I'll present at the end of the talk. All right, so let's get on then. So first of all, I want to talk about this is a chart that I got from this article from Start Active, Stay Active in the UK. Is by our chief medical officers from all of the country. Is on this paper, it actually suggests that we should do some exercise and how we can encourage people to do exercise and how we can stay fit and stay active, and how good exercise is medicine and how we can treat people. But what I want to take out from this important document that is to show that not all exercise are the same. You can see some exercise are more focused to improve muscle function, and some exercise are more important to improve bone health, and the other one is balance. Of course, you must know already depends how intense the exercise is, the way that the body reacts is very different. A very, very simple thing that you want to look at is that there is a very, very different between walking, running, and Nordic walking. It's a similar motion by doing this sort of movement. But the key is that for me to show this slide is to show that not all movements are equal. Some movements are better than the other in specific thing. But then, why is that the case? So this is the bit that I want. This is the little introduction for me to talk to you about why we want to look at such thing and how do we understand our body move and how our body utilize the energy, and we need to learn a little bit about muscle homeostasis. Hence, I'm going to break this down the lecture into two approach. One is talk about how our muscle utilize energy, and the other one is how our muscle balance itself. So let's talk about the energy first. How did our body use energy? How does our skeletal muscle use energy during exercise? Now, most of you would have known this from your textbooks or from your physiology days or from your medical textbook days. The good news is it has not changed. It's still the same thing. Essentially, there's only three things that we can use to make energy. And the most important thing is ATP. ATP is where all the energy source coming from the body, and it can get it from either glucose or fatty acid. I'm going to break that down into much more small chunks so we can understand the pathway. Then we can understand how our body can be enhanced by using these method to help us. So this is from this chart that I got is from the paper from the Nature paper that I showed you earlier on, and it is how the body used the energy. It looked a lot of equation, a lot of numbers on there, but actually essentially what it's saying is that the body utilized ATP to produce energy, to ATP with some water become ADP, and then it will release about a small amount of energy out. So that's basically how the body breaks down. It's just biochemistry. ATP become ADP, and then one of the phosphate get released, and that's how the body gets its energy. Now, that equation doesn't change. That's always going to be there. So the key on this equation really is ATP. There's only a certain amount of ATP in our body. When that ATP is finished, we want to reproduce it. If we don't reproduce it, then the body will finish. There's no ATP left, and therefore they got no energy. We cannot move. So therefore, this is really important. The ATP resynthesis is extremely important. So looking at this equation down here is, you can see PCR, which is phosphorylated creatine. So this is basically how the body collect the phosphate in there, and plus ADP, it will form ATP plus creatine. So basically, the body has stored phosphate within a creatine, and that's why it's important, and that's how it can turn the ADP back into ATP. The other way that the body can regenerate ATP in a much better fashion is, you can see that with glycogen. Glycogen with free ATP, it will form free ATP, and also it will form lactate, 2 of lactate. And we know what lactate does. Lactate, will become lactic acid, and it was when we feel our burns. Now, so you can see ATP resynthesis does not require oxygen in these two equations. However, it doesn't reproduce very much ATP. It's 1 to 1. This is 3 to 3. So it will take a very long time to regenerate a huge amount of ATP. So that's where the oxygen come in. So this is oxidative phosphorylation. So that's when the glucose and the oxygen come in, and you can see they can do 36 ATP at a go, and one equation. And if you use the next equation below, we can actually use 130 ATP, will get converted 130 ATP. So it is a much more efficient system, and you can produce a lot more ATP with the other system when oxygen is present. So think of it as using a single core computer versus using a 24 core computer. So things are a lot quicker if oxygen is around to regenerate. So this is, and therefore when there is oxygen, our body can continue to do exercise, can continue to move, because the energy will be there. Now let's go down to the nitty-gritty about this this ATP and ADP, and also of how the body get the energy coming from. So again, this is the diagram that I taken from this paper from Nature recently. So first of all, I will break this down. It's quite a complicated diagram, but I'll break it down. Hopefully you understand when I explain what's happening. So first of all, in here at the top here, this is the myosin actin fiber in there. So all you need to think of it as, when there is energy, this little ball will move. The muscle can only contract, so it will basically move one atom along. So when there's ATP, when there's energy, so ATP become ADP, and then by doing that, they release the energy for this muscle to move one contraction to go across. So that's how the muscle contract. Now, once the ATP form to the ADP, then it will then release the energy, and we'll have that extra phosphate lying around. And we talk about we need to recycle this ADP. So the first way to recycle the ADP is with that phosphate in the creatine. So the creatine will pass this ADP on and push it to the ATP. So that cycle can keep on going and going and going again. And again, once this is settled down, and on the other hand, when the muscle is not moving, when there's ATP hang about, this again can help the creatine to become creatine phosphate. Now, then that's the next part, is look a little bit more complicated. So that is when there is glucose. So the body utilizes glucose, and glucose come into the body, and it go through this cycle and form pyruvate and lactate. And that's what ATP will happen in there. So that's when it actually form the, a little bit more of the ATP, as we saw in the last equation. Now, and then what happened in here, which is really interesting, is that when the waste product or the byproduct is a pyruvate from the glucose, it either turn into lactate, and we'll talk about the lactic acid, or this pyruvate can then go into the mitochondria. When it go into the mitochondria, it has some sort of chemical reaction happen, and some sort of biochemistry happen, and then it went to the Krebs cycle. By doing so, it then form more ATP, and then it will form carbon dioxide. Now, the important thing in order for this Krebs cycle to happen is the oxygen. So we need oxygen. The oxygen to go in here to exchange it to become water in here, and then through some clever biochemistry, it will actually help to trigger to push this pathway along to form more ATP within the body. So that's how the body usually utilizes energy, and why oxygen is important. You can see without oxygen, the mitochondria pathway is not happening. So all the pyruvates in here will turn to lactate instead of entering the mitochondria to form further ATP, oxygen, and carbon dioxide. So this is why it's important to have aerobic respiration, so therefore you don't get as much fatigue as easily because of the metabolite of lactic acid. Now, just for completeness, I want to show you another way that the body will take fat, will use fat as fuel. So you can see this is FFA, which is free fatty acid. It goes into the cells, and then it get broken down, and then it actually gone through the same pathway in the mitochondria. And again, at the end of the day, it will still have to go through this the Krebs cycle in order for it to produce ATP. And you can see very clearly that, as I mentioned before, you have to do it with oxygen. Without oxygen, the body cannot turn fat into energy. So that it depends what we're trying to achieve. If we're trying to achieve fat burning, we need to do some aerobic exercise. But then if we are actually, that is not our goal. Our goal is actually to get movement. So we may not want oxygen to enhance our body to build. Now we go through that in the next few slides. Okay, so this is another diagram here, again from the same paper, but this time is not as complicated. Again, what's shown on this side has been said. So this is the bit I want to talk about in the American Physiological Society. We have got, this is a very interesting study that they have done. It is a very crazy study from the way I read it. They try to push somebody to do maximum exercise as much as they can, as hard they can. They push it to the absolute maximum limit. But then what they will also do is they take a muscle biopsy into their thigh, 6 seconds, 15 seconds, and 30 seconds, while they are doing a complete exhaustion of cycling within the first 30 to 60 seconds. So on here, we can see that how the body use different source of energy to make the energy for the muscle. You can see here the first 6 seconds it used creatine and glycolysis, which is breaking down glucose and form a lot of metabolite. And then it takes a little while for the body to kickstart the oxidative phosphorylation pathway to actually make more efficient ATP production on this sense. Now, it is a scientifically proven, and actually this is a very interesting study to teach us that, this is how the body tend to happen. And then as the exercise carrying on, this ratio does not really change, because the body is designed to get rid of this waste product and try to continue to do the exercise. So therefore, the oxidative phosphorylation will keep on coming. So this is a exercise to another diagram from the same institute to basically show that with different sort of exercise and different intensity, the body use slightly different sort of energy to source to actually exercise. Now, if you exercise in 85%, you tend to use a lot more body glycogen, and you tend to use less of the glucose. So different way of different intensity training, we use different fuel and we use different source. And we know that in recovery, in physiotherapy, and in muscle building, that actually is the high intensity training that will make the difference. Yes, the high intensity training will tear, we cause micro tear with this fiber to actually make the muscle rebuild. However, the really important thing is the biochemistry, is those chemical, is the anaerobic restoration and this metabolite that I talk about, the lactate, the uric acid, the ammonia, that actually stimulating the muscle to grow. And then I will go through that in the next few slides and what these guys actually does to the body. But this is just a memory, just a revision of different intensity of exercise do different things. Usually, if you want to build muscle, you want to go high intensity instead of low intensity. Low intensity is lower intensity. It's actually good for fat burning, for cardiovascular fitness. But what we need to understand is when we doing rehabilitation, especially in MSK, in musculoskeletal work, we are not training cardiovascular. We are not training CVS. So what our approach need to be slightly different. We need to think differently. By applying the CVS rehabilitation or the CVS science, or someone that's going to win a marathon, those science into someone want to train, want to build a muscle following surgery, it doesn't apply. So we need to think differently. All right, so enough about the energy and about the metabolism in the body. The next thing is talk about my favorite topic. So that's muscle building and strength. And again, another very complicated diagram about biochemistry. This is a very, very important pathway. It's very simple. It's not all these is not all these little number and cytokine is important. The only 2 or 3 of them is important, which is the AKT and the mTOR. These are the only important things that we need to know about. It's called the AKT-mTOR pathway, and that is the only pathway that in the body that if any muscle growth, that is what responsible to it. So I have summarized this into my next drawing, which is here, which is very simple. So this is the cell, and there's a receptor outside the cell. When growth factors or insulins or growth hormone enter the cell, what will happen is that it will stimulate the AKT, which is a cytokine that it will push, have a positive effect on the mTOR complex. mTOR is stand for something quite weird. It's called the mammalian receptor for rapamycin. It is a story that for some other time, but it is a receptor that will in charge of synthesis and building and push the ribosome in the body to push up to make protein synthesis, glycogen, anything building. Basically, give the signal, tell the nucleus to say now you need to produce this amino acid. You need to form this amino acid chain. You need to build the body, and that is this is why AKT-mTOR pathway is extremely important. Of course, like anything in our body, the AKT-mTOR pathway, and for mTOR, for it to active, it will have a negative feedback to the receptor. When this is active, it will make the receptor less sensitive to the growth factor. So therefore, will prevent further binding of this receptor. And that's how generically how the body works, how we actually ask the body to build, how we build muscles, and that is what the pathway will work. Now, so once we talk about that, we want to talk about we want to start thinking about what we are trying to do. As I earlier just mentioned, when we're talking about MSK rehab, it's very different to cardiovascular rehab or even on respiratory rehab. They are very, very different things. What is our objective? What do we try to achieve with MSK rehab? It is not the same thing with cardiovascular fitness. It should not and does not apply, at least at the very beginning. Yes, of course, once the patient is getting better, when they have trained better, then yes, we want to push their cardiovascular fitness. We want to go back to return to play. But what I'm talking about right now is at the very beginning. So this is our clientele usually, my clientele at least, either they have osteoarthritis or they have an injury or they are after the operation. So these people all share some common factors. So the limiting factor for any rehabilitation with my clients usually are pain, pain, and pain. They are unable to live very high low, and they cannot do prolonged exercise, or they may not want to because they are painful, they just had surgery, they didn't want to do things. So it is very different to a different type of rehab, or neuro rehab and cardiovascular are very, very different. Now, in terms of our challenge, for our patient, we want to rehab them, we want to rehab them in a safe environment. But at the same time, we want to stress the body enough. We want to give them the right intensity. But because these guys are in so much pain, they have so much limitation, we were never going to be able to train these guys at 100% in the intensity. It doesn't make any sense. And actually, another factor is that we are not training them for VO2 max. We are not trying to improve their cardiovascular system. So the limitation factors within MSK post-operative rehab or pre-op rehab, it really never ever is oxygen. Oxygen was never the limiting factor in these patients. The limiting factors usually is pain or motivation in the body or safety. Now, the next thing I want to talk about is, what do we normally do during rehabilitation? Because patient is in so much pain, we don't tend to push as hard as I just talked about. We may give them 50 to 60% of maximum effort in their comfort zone. Sometimes we might not even be able to. If they're injured, they may only be able to do even 5% or 10%. So really, there's not much stimulation in the muscle. There's not much metabolites around. We're not tearing those muscles. We may keep the range of motion. That's about it. There's nothing to trigger there's nothing to trigger the metabolic response. There's nothing to trigger the chemical or physiological response. We need more than 50 to 60%. We need to have those anaerobic respiration to create this metabolite, to stress those body, at least chemically, if we can't stress them mechanically. So this is what we need to think about during our rehabilitation. We need to think chemical as well as physical. So this is a very simple slide that is again another factors that we need to take into account of. As you all know, that our muscle mass and strength decrease with age, and this is a very interesting graph in here to show that our peak of our muscle mass is roughly when we're 25, and then after that it's all downhill from there. Now, if you look at medical definition about osteopenia, there is something similar for lack of low muscle. It's called sarcopenia. So basically, it's 2 standard deviation below the peak of the muscle mass. So if anybody over the age of 60, 70, certainly by 80, they are definitely into the sarcopenia group. So they may not have enough muscle mass for them when we are trying to rehab them. For example, after total knee replacement. So therefore, we are starting in a much worse off place. So if there's not enough muscle mass there, we know that through our other work, our fracture, our trauma work, the effect of immobilization with our patient, the muscle wastes away very, very, very quickly. This is one of the studies that was done many, many years ago to show that if you immobilize someone 2 weeks in plaster, their muscle mass reduced about 5%. You may say that, well, 5% is nothing, it's a little bit, it doesn't really matter. Actually, it really does, because although the muscle mass has lost much, what has lost a lot is strength. 30% reduction in strength with only 5% of muscle mass reduction with 2 weeks of immobilization, which is very, very extraordinary. The reason that we see that is because due to trauma and inflammation. And you can see there is a high level of IL-6 as well as TNF alpha released into our body. So it's a chemical that can cause the problem. With the chemistry and immobilization add together, we're actually really severely affecting our muscle fiber. This is a very good study from patient that in intensive care unit who is critically ill versus someone that is not critically ill, and someone that is critically ill and immobilized. You can see that the there's very big changes of this histology slides here. This is relatively normal. You can see all these muscle fibers nice and plump. But if you can see on this diagram below, the type 1 fiber, the slow twitch fiber, they still okay. But the fast twitch fiber, the 2A and 2B, they really wasted away following injury and immobilization. So actually, we can apply that principle to our elective surgery, to our injury, or to our rehabilitation process. At the very beginning, when someone had trauma, we do not want to immobilize them. We want to make sure they will be moving. Now, we want to make sure they move, but then actually in a lower intensity that can still stimulate the body to stress those muscles, to stress those fiber to continue to at least not waste away too quickly, or if not grow. That's another interesting study from the Journal of Physiology. In this one, it has shown that what about, if we just give patients some growth factors and don't do any exercise, will that work? Can we actually prevent patients to have muscle, don't lose their muscles and keep their muscle mass? Actually, these studies have really shown that by just doing one thing, by just giving growth hormone doesn't really do very much. Exercise really do something good, but then when the moment that we combine growth factors or hormones or metabolite with exercise, that is when things make a huge difference. So hence, we need to, when we think about treating patient, when we think about rehabilitation or muscle building or prehab, we need to really think about chemistry as well as biology, as well as mechanical, physical movement. So that's hence that lead me back to the talk of the blood flow restriction training. So what is BFR? So BFR is basically something that restricting the blood flow. Long time ago, people called it occlusion training, but I really do not like that term. We do not want to occlude anything. We want to just reduce the blood flow. Occlusion training is a very, in my books, is a very, very bad idea, because occlusion means you stop something going, right? So if we stopping the blood flow from one to another, we are actually putting someone in danger. So for example, we're putting a big tourniquet on someone's thigh, and then we blow it up, we stop all the blood to go down there. What will happen? So there is, in medicine, there's something called the Virchow's triad. This is the three things that we don't want things to happen, and that's how clots are formed. So we do not want any damage in the vessels, in the blood vessels. By squeezing that blood vessel, occluding them, we will ultimately cause intima endothelial damage within that vessel. So that's vessel damage. We do not want stagnant blood, but by occluding that blood vessel, nothing flowing, the blood has become stagnant. And then finally, we don't want turbulent flow, but then there's no flow that's worse than turbulent flow. So actually, occlusion training have an extremely high risk of forming clot. Now, this is why it's very, very dangerous. And I do not think that, I think it is one of the reasons that why that has not taken off in medicine. It has been taken, it took off quite well when for people that like to do bodybuilding, because it really helped the muscle to grow. But in medicine, it's quite dangerous to use occlusional training. However, if there is a way that we can ensure that we monitor that blood pressure to ensure this blood is flowing all the time, we do not stop that blood flowing and reduce that chance for that blood to clot, and in a monitor control manner, I think it's extremely useful, extremely powerful. And hence, that's why I was looking at BFR and I'm interested in BFR. Now, I can talk to you about the basic science of BFR and how does it work. Now, do you remember this diagram that I showed you before, the AKT-mTOR pathway? So you remember our cells on the outside, and you can see that the receptor at the top here, and then same again when our insulin or our growth factors hitting those receptors. Remember what happened? Will trigger the AKT-mTOR pathway. So therefore, things are starting to grow. The body is in a synthesis mode, is an anabolic mode, everything happy. Remember I said there is a negative feedback from this mTOR pathway. So therefore, make this receptor less and less receptive to growth factors. So the body will not just forever continue to grow. Now, this is the next thing. The next concept is quite important, because that's explain how I think BFR is works and what is the scientific basis behind it. So you can see I draw another box here, which is say the local. This is a local factor. Okay, so this is what happened locally in that one cell. Now, if you can see that mTOR complex downregulate this receptor. Now, there is something that this is external factors. Okay, so these external factors, for example, exercise, DNA damage, deterioration of glucose, hypoxia, will lead to downregulation of the mTOR complex. Therefore, it has a double negative feedback into that receptor, which means that it will make this, so we dampen this down, so therefore this will become more sensitive if these factors are there. Now, these are external factors that's outside our body. So in order, usually for us to achieve these external factors, we have to really stress our body. We have to stress the whole system of our body. For example, you may need to run for an hour or 2 hours before you have these sort of things. And you may not have a hypoxia. You may not have glucose deprivation if you're a trained athlete. If you have planned your journey well, or you may not have high enough intensity to actually trigger this sort of response. Okay, so this is where BFR come in handy. So you can see here in the BFR, when we put the BFR on, when we do the exercise, it will cause oxygen deprivation because not enough blood supply, or not enough, but the blood will contain glucose as well, so they are not turn around that quickly, and also the hypoxia effect will be there, and that will cause the body create all this metabolite to have that negative effect on this mTOR complex, which in turn will make this receptor more sensitive during that time. Now, this is where the key come in. We then turn that BFR off because BFR is not there forever. We turn that BFR off. Suddenly, on the rest of the body, we have oxygen-rich, glucose-rich, and ATP-rich. Everything suddenly is rushed back into it. And also within our blood, there will be high level of growth factors and high levels of a cytokine that will actually trigger this receptor. So imagine at the moment that we released this BFR tourniquet, these receptor will rush into bind this really sensitive receptor to actually push this pathway along and push this synthesis happening. Now, once these receptors is binded by hormone and growth factors, they last for quite some time. It doesn't stop there. It's not just bound in and then it's negative feedback, it let things go. No, it doesn't. It bound in there, it will continue to produce that response until this growth factor be, naturally be degraded. It will take some time. So actually, the response of the body have suddenly increased. So the amount of oxygen, so the oxygen actually come back. So actually, they can push on this pathway to get the body to start building. So that is why I think that BFR have a chemical response to the body as well as a physical response to the movement. We talked about lactate before. Lactate is another very, very important thing. It's a study that was published back in quite recent 2021, looking at how lactate working, how myoblast is working, how lactate can actually stimulate early myoblast differentiation, which suggests that these metabolites will help our body, help our muscle cells. Myoblast is basically cells that will form muscle. So muscle cells are sensitive to it and help them differentiate to build. So it is something that is quite interesting. Okay, so after all this biochemistry and all this paper that I'm going to show you, I'm going to summarize in a very simple fashion how does BFR work. So here it is. BFR is like a cocktail that the body produces chemically to stress and push the muscle cell to push past the anabolic pathway. Think of it as a custom dose of chemical produced by your own body to push growth. That's how it does. And that limb, while it was having blood flow restriction, during there, these metabolites will produce a tailored cocktail of lactate, ammonia, uric acid to actually stimulate and push this muscle to growth. Okay, So as I say, talked to you about, so you understand how BFR work, what is the basic science behind BFR, the biochemical basis of BFR. We can look at some evidence. Are there any evidence? Am I just randomly just think, oh yeah, putting a tourniquet on the leg is quite good. So this is one of the evidence that we've seen from the Journal of Sport Physiology and Performance. It has shown that they make a big difference. It actually stimulates improved strength and power for 3 weeks. Now this is occlusion training in there, but when I'm reading through the paper, it's not just occlusion training. It is blood flow restriction training. It is monitored. So this is so it actually push the chemical as well as the physical effect as well. And then finally, I want to go to this paper. This is the one that I talked to you earlier on about a systematic review on the on blood flow restriction training. Now, why do I pick this paper? This is a very interesting paper because it is not just on any random person. It's not on athletes, because I know we treat athletes a lot of the time, but this paper is specifically on older individuals. So this is looking at 11 study over 230 patients. That is 50 years or older patient only. Anybody younger than that is excluded. So because a lot of our clientele in medicine is usually slightly older. So this is the forest plot that I cut out from the paper. So forest plot is basically quite simple to look at. If anything on this side, so they draw a triangle for you. If anything on this side is no good, if anything on this side is good. And so after they plotted all the study on there and look at it, does it make any difference? Yeah, it make a little bit of a difference on here. So what is this graph showing? So that's LLBFR to LH. What's that mean? So they're comparing of low load, so low intensity BFR to high intensity training. It showed that BFR is favorable, so even but it's 20% better. Not a huge amount, 20% is okay. But remember, what did we say? Our patient, our clientele cannot have high load. They cannot go under high intensity training because of pain. So if they can actually tolerate low load. So if you give them low load BFR training, it's actually 20% better than high load. Sure, it's a sure win, right? Now, they also look at the muscle strength on low load BFR compared to standard low load training. So does that tourniquet really make that much of a difference? And what it has showed that yes, it does. It is 86% better with the tourniquet putting on top of it, and that's from this meta-analysis. However, what is even more interesting is this slide here. This is astonishing. They have actually demonstrated that with walking, with the BFR putting on, instead of doing a low training, actually 20 minutes of walking with blood flow restriction training have highly stimulate muscle strength as well as muscle mass. You can see the effect size here is 2.16, which is 200 times better. It is double, 200%, not 200 times, 200%. It's double to when you're walking without any BFR. And in terms of muscle mass as well, it is 3 times more. So actually, it is something that is quite useful. With a lot of our patients maybe only just be able to walk, and actually, if you walk the patient with 20 minutes of BFR, make a huge difference in muscle mass and muscle strength. And that is from the meta-analysis from this from the Journal of Sport Medicine. Now, I have talked enough, so I hope that you got loads of questions and we'll hopefully be able to answer it. And in summary, what you have learned today is about why did the muscle need ATP, how and where we get the ATP from. Without the ATP, the reason that we need oxygen is we want to carry this on. But if we want the body to push onto the anabolic respiration, we want to get rid of the ATP, because in the anabolic respiration, that's when we push, we can actually stimulate and make the AKT-mTOR pathway into overdrive that will stimulate muscle growth and strength. Metabolic is needed to make this pathway happen. Don't forget about age and movement will relate to muscle wasting. And in summary, really, the BFR can produce higher metabolite in a lower intensity in a much safer environment. it's quite good evidence for its effectiveness. And the other thing is, one thing that we notice in our practice is that we tend to be able to take charge of the patient's rehab journey a little bit more, because we got they will have set a time, come to visit us, and then I'm sure Paul Lewis will talk a little bit about that when it comes to our patient journey. So a lot of patients that you try to tell them to do some exercise, they might go home and don't do the exercise. But actually, if they know that they come in here, they do this exercise with the BFR, then they don't have to do much when they go home. Yeah, we want them to do something, but sometimes they doesn't do that. And also, we will be able to help the patient to guide them through the journey with this specific training. Now, so that's the summary of the talk today. This is some future webinar talks on BFR. We can talk about which muscle we can use it on, when to use it, how to use it, how easy is it, and what is our clinical result from our clinic, which I'm not going to talk about today because I think I talked quite a lot already. It's almost half an hour. And this is the end of my talk. So if there's any questions, please feel free to email me. And we do have other talks and other things on our YouTube channel. You're more, very happy for you to come and join it. We talk about many other things, mainly biology and regeneration. And that is it for my talk. So